Welcome to the third part of our virtual case-based symposia, New Strategies for Multiple Myeloma Care, Case Studies for Nurses. Today's 1.5 CNE credit discussion is broken into 3 parts for your convenience, each of which is worth 0.5 CNE credits. This is part 3, where we will discuss heavily pretreated myeloma and new drugs in development. This symposium is held in conjunction with the Oncology Nursing Society's 2020 Bridge Meeting. My name is Beth Faiman, and I'm a nurse practitioner in the Department of Hematology and Medical Oncology at the Cleveland Clinic Taussig Cancer Institute in Cleveland, Ohio. To begin the discussion of heavily pretreated myeloma, I'll turn the discussion over to my colleague, Tiffany Richards. Tiffany?
Thank you, Beth. I'm Tiffany Richards, a nurse practitioner at the University of Texas MD Anderson Cancer Center. In today's discussion, we'll be discussing heavily pretreated myeloma and drugs in development. Our learning objectives for today are the following: identify common treatment regimens in heavily pretreated myeloma, and apply knowledge of nursing management for myeloma patients, including effective symptom management. We're going to first talk about Carl. Carl is a 63-year-old gentleman who was diagnosed about 10 years ago in 2010. At that time, he was found to have high-risk disease with a gain of 1Q. He is initially treated with thalidomide and dexamethasone. However, his therapy was changed to bortezomib and dexamethasone because he did not have a sufficient response. He went on to an autologous stem cell transplant and then was placed on lenalidomide maintenance. He remained on that for several years. However, he then developed disease progression and was placed on a phase 1 clinical trial of carfilzomib single agent. He remained on that for about 2 years, at which time he relapsed and was placed on elotuzumab, pomalidomide, and dexamethasone. He subsequently had another relapse after about 6 months and was therefore placed on daratumumab, bortezomib, and dexamethasone. So he's now 73 years old. However, he started to have problems with his platelets dropping. He was also found to have some anemia and a little bit of neutropenia. And so we obtained a bone marrow biopsy to ensure that it was myeloma and not due to another cause. When we saw his bone marrow, it showed a heavily infiltrated marrow with myeloma cells. Additionally, he was found on FISH to have a translocation 1114. So when we talk about options for relapsed refractory myeloma and a later time of relapse, we have a lot of different options. We have newer options such as selinexor in combination with dexamethasone. We have panobinostat in combination with bortezomib and dexamethasone. We have cyclophosphamide that we can use in various combinations, either with immunomodulatory agents, proteasome inhibitors, or even more intensive chemotherapy such as DSEP or VDT-PACE. We also have other drug combinations that the patient has not received and possibly retreatment with prior regimens if the patient had a great response and does not have signs of resistance. And then, of course, there's always clinical trials that are always an option, as well as newer agents. We're going to first talk about selinexor. Selinexor was recently approved in July of 2019. It works by blocking tumor cells from exporting tumor suppressor proteins and thereby causing selective apoptosis. Selinexor is approved in combination with dexamethasone for the treatment of patients with relapsed refractory multiple myeloma who've received at least 4 prior therapies and whose disease is refractory to at least 2 proteasome inhibitors such as ixazomib, carfilzomib, or bortezomib, at least 2 immunomodulatory agents such as lenalidomide or pomalidomide, and an anti-CD38 monoclonal antibody such as isatuximab or daratumumab. When we start a patient on selinexor, we really need to make sure that we're educating the patients about side effects. A lot of times patients think that a pill means that it's easy to take. However, with selinexor, we do know that we have to closely monitor these patients, particularly for the first month. Once we get them through the first month, we generally see a decrease in the side effects that they see. So it's really important that we're monitoring their blood counts for thrombocytopenia and neutropenia. We need to be monitoring their electrolytes because they can develop hyponatremia, and it can occur very quickly within the first several days. So you want to make sure, at least for the first month, that you're bringing in patients in about twice a week or more, depending on what their counts and their electrolytes are doing. You want to make sure that you start them on prophylactic management with anti-nausea. So you want to place them on a 5-HT3 antagonist such as ondansetron, as well as olanzapine and or aprepitant. You want to make sure that patients are starting these antiemetics on day 1. You don't want them to wait. You want to make sure that they're able to eat and drink, and that if they're not able to eat or drink, that they contact the clinic, or if it's over the weekend and they're having problems with diarrhea, that they know that they need to come into the emergency room. You also want to make sure that your patients know how to manage potential diarrhea. So you want to make sure that they have Imodium on hand and that they don't wait until they start having diarrhea to get it. So again, it's really, really important that you're educating your patients on the proper management of these side effects and that you're bringing them in for close monitoring. Additionally, we usually start patients at the beginning of the week. That way, if they start to have problems, it's still within the clinic week that you can get them in to be seen. So more recently, there was consensus recommendations that were published in the Clinical Journal of Lymphoma, Myeloma, and Leukemia. And Beth Faiman was one of the co-authors on this consensus recommendations. And I think this would be a highly valuable paper to have within your practice to help you manage patients who are receiving treatment with selinexor. If we look at the data from the STORM-2 trial, if we look at the response rates with this regimen, we can see that the overall response rate was 26%. Now keep in mind that the median prior lines of therapy was 7 in this study, which is pretty impressive. So while we think 26% may or may not be a lot, if we consider that bortezomib and lenalidomide as single agents had very similar response rate, and these patients have had a lot more prior lines of therapy. They even saw 2 patients with stringent complete remissions, which usually for patients that have had this much therapy, we rarely see that. In fact, 2 patients who had prior progressive disease after CAR T-cell therapy achieved a partial remission. The median time to response was 1 month, so generally very quick responses. And the overall survival in patients who had a minimal response or better was 15.6 months, whereas in patients who didn't have a response, it was 1.7 months. And it was a median of 8.6 patients for all patients. Now remember I had mentioned how important it is to monitor our patients closely. And if we look at the adverse events that was seen in the STORM-2 trial, we can see that there was myelosuppression such as thrombocytopenia and neutropenia. And there was grade 3 and grade 4 was about 27 to 30% for thrombocytopenia, about 21% for neutropenia. So again, really important to monitor these patients for blood counts. If we look at non-hematologic events, we could see that most of the adverse events were all grades, with the exception of fatigue and hyponatremia. So again, making sure that we're educating patients. And about half the patients did have a weight decrease, so you want to make sure that you're also monitoring your patient's weight while they're on therapy. So we're going to talk about the Boston phase 3 trial, which compared selinexor, bortezomib, dexamethasone to bortezomib, dexamethasone. Now in this trial, there are 402 patients with relapsing disease, and they had 1 to 3 prior lines of therapy. Now in this study, selinexor was given 80 milligrams once a week, along with bortezomib once a week and dexamethasone. In the bortezomib arm, bortezomib was given twice weekly, along with dexamethasone. If we look at the progression-free survival, we can see an improvement by about 4 to 5 months with the selinexor compared to the bortezomib arm. Additionally, the overall response rate was higher in the selinexor arm at 76% versus 60% in the bortezomib arm. Additionally, we saw improved tolerability with the selinexor arm as far as thrombocytopenia, fatigue, and nausea. Now, they did see an improvement in side effect profile with the lower dose of selinexor, 80 milligrams once weekly. That tells us that maybe using a lower dose of selinexor makes the drug a little bit more tolerable for patients. But again, these patients still need to be monitored closely. So we're going to talk about clinical trials and the different phases of clinical trials, and it's really important that patients understand what clinical trials are and the different phases and how it can provide early access to promising treatments. So phase 1 is when we first introduce a drug into humans. And the purpose of a phase 1 trial is to determine the maximum tolerated dose, what the dose-limiting toxicity are, the metabolism of the drug, and other pharmacologic actions. We're really looking at side effects. How do we manage those side effects, and how high of a dose we can get in a person without causing too many side effects. We do gain some early evidence of if the drug is effective or not, but that's really not the purpose of it. And generally, it's composed of 20 to 80 patients. Now in phase 1, we have their dose escalation studies. So they start at a lower dose, and then they gradually increase the dose of the drug until they see too many toxicities. Phase 2 is where we begin to look at the effectiveness in a certain tumor type. So we are also, again, looking at the side effects of the drug, but also looking at how well does it work. And phase 3 is where we compare the investigational agent compared to standard of care. So for example, in the Boston phase 3 trial, we were comparing selinexor bortezomib dexamethasone versus bortezomib dexamethasone. Now these studies are often multiple institutions because they have such a large number of patients that are enrolled, and they can either be single or double blind studies. And then phase 4 are approved agents in new populations or new dose forms. Now you may be wondering, how can I find clinical trials for my patients? Well, the International Myeloma Foundation has made it very easy for you. So you can go to the Myeloma Matrix at www.myeloma.org/matrix, and you can put in your search criteria. So you can search within a certain miles of a zip code. You can filter by newly diagnosed, smoldering, maintenance, relapse refractory, or maybe you want to know where all the clinical trials in myeloma are. And then you will get a list of all the available trials for your patient. And so they've made it really handy for you to be able to get that information. And then you can also call the IMF info line as well to obtain that information. Beth, now that we've reviewed Carl's case and a few of his treatment options, including how to gain access to clinical trials, do you think there are other options which should be considered?
Yes, Tiffany, thank you. You know, Carl had a translocation 1114 on his bone marrow, and nowadays I get so excited when I look at people's FISH results and I see a translocation 1114, and part of it is because of this venetoclax trial, the Bellini trial. So patients were randomized to bortezomib and dexamethasone with or without venetoclax. So what is venetoclax? Well, it's FDA approved in chronic lymphocytic leukemia and AML, and it's BCL2 is actually the gatekeeper to the apoptotic response. And so BCL2 contributes to tumorigenesis by blocking that programmed cell death availability. So if you inhibit BCL2, then cells die. And what we know is that it works real well with bortezomib. So in this study of 291 patients with 1 to 3 prior therapies, they were treated with bortezomib dex plus or minus the venetoclax, as I mentioned before. We saw if patients had a high BCL2 expression or translocation 1114, the progression-free survival in these patients was 23 to 24 months with the 3-drug combination versus 11.4 months with the 2-drug combination. Overall survival was longer, and the MRD negativity was higher if you had the translocation versus not. And so again, this is currently FDA approved in CLL and AML. We can see deep responses. I think this on the horizon is one of the first personalized therapies we're going to see for patients with myeloma. If patients want to have this and they can't get on a clinical trial, maybe they'll go to the Myeloma Matrix and find there's some ongoing venetoclax trials currently available. Maybe they'll go to the Matrix. If they can't participate, then sometimes we're able to get this approved through the insurance company or through the pharmaceutical manufacturer. So again, be on the horizon. 1114 translocation is not a bad translocation to have, but if they have it, then maybe consider venetoclax would be right for them in relapse disease. What we do know is CAR T-cell therapy is one of the best available therapies for leukemias and lymphomas, and now in multiple myeloma patients, especially with the BCMA target with the CAR T cells, we're seeing some very positive response. I'll tell you some clinical pearls, and then I'd like to go into a few different treatments and studies that have been reported. So first of all, CAR T cells engineer a patient's own T cells, and that takes roughly about 4 to 6 weeks. And during that time, patients will need a bridge therapy or lymphodepletion with usually cyclophosphamide and fludarabine. So again, you take your patient's T cells with a chimeric antigen receptor DNA, it's grown and reinfused in the lab, causes T cell mediated death, and then again goes to target that BCMA or other antigen. And there are different CAR T cell products that I'd like to go over now just briefly. So the KARMA phase 2 clinical trial was with ide-cel in relapsed and refractory multiple myeloma. Many of you who have been practicing myeloma for a while or taking care of patients might have heard it been called BB2121. So this is one of the oldest CAR T cell BCMA therapies in myeloma, and this study has 128 patients, again, with relapsed refractory disease greater than 3 prior therapies, including a proteasome inhibitor, an IMiD, and an anti-CD38 or refractory to the last regimen. So in this heavily pretreated population with a median of 6 prior therapies, we still saw a 73% overall response rate. Now, patients were dosed at an escalation of lower or higher doses, and we know the higher dose of the ide-cel will probably be better, but you have to manage that against the toxicity. Cytokine release syndrome is a very serious complication of CAR T cell and the bispecific T cell therapies, which we'll talk about. And in this study, we saw 5% had a greater than 3, but fortunately they were of different degree, lower degree, 84%. And what we know is that it is an effective therapy in relapsed myeloma. Now, the EVOLVE trial was a phase 1/2 clinical trial with Orva-cel. So Orva-cel CAR T therapy also targets BCMA. And in this study, 44 patients with relapsed and refractory myeloma and greater than 3 therapies, very similar to the ide-cel study we just talked about, 91% had an overall response rate. Now, cytokine release syndrome was managed with tocilizumab and or steroids in 78% of patients, anakinra, and vasopressors. A lower incidence of CRS was seen in this. What's nice is that a median progression-free survival has not yet been reached at the median follow-up of 5.9 months, so stay tuned for additional data on that study. Now, the next one I'd like to talk about is the CARTITUDE-1 phase 1b/2 clinical trial by J&J 4528. Now, this has 2, not 1, but 2 BCMA targeting domains. And in this study, up until January of 2020, 29 patients with progressive multiple myeloma, again greater than 3 prior therapies, 100% overall response rate. And these data were just updated at ASCO as well. There are deep responses. 66% had a stringent complete response, and it was 1 month until the first 1 to 3 months. Again, these therapies need a lymphodepletion regimen of cyclophosphamide and fludarabine, and they need to manufacture the CAR T cells to then be reinfused. Now, the T cell engagers combine a monoclonal antibody targeting with a T cell activation domain. So they're all generally with CD3, and then it binds to something else like CD38 or CD269 BCMA or others. So the AMG or Amgen has 3 different molecules right now. What these T cells, what this bispecific therapies do is they engage T cells to do what they're supposed to do, fight tumor cells. So we've seen some very effective results to these clinical trials, but these also cause cytokine release syndrome, which I've alluded to in the CAR T cell therapies. So again, cytokine release syndrome occurs when all of these bad cells will kind of explode and cause an inflammatory response. And this can invade organs such as liver, kidneys, bowel, brain. And this can be very serious and life-threatening for many people. Again, we know tocilizumab, dexamethasone, and other agents can treat it, but patients should be aware that this is a side effect of therapy and potentially very serious. Now, Tiffany, there are some important treatments that are here, and I'm so excited to say belantamab mafodotin, melflufen, these are now new drug classes that we can offer to our patients. So, Tiffany, can you tell us what nurses need to know about these drugs?
Yes, I'd be happy to. So Beth, this is a new drug class with unique mechanisms of action. Belantamab mafodotin is a humanized monoclonal antibody drug conjugate that's currently in development. It is a humanized IgG1 antibody that targets BCMA. and it's linked to an antimitotic agent, MMAF, and through this, it also enhances antibody drug-dependent cytotoxicity. BCMA plays a key role in plasma cell survival, and it's actually overexpressed on the surface of myeloma cells. So this is going to be a new modality in myeloma. It'll be our first antibody-drug conjugate, and it's really easy to administer. It's only given over a 1-hour infusion, and the patients come in every 3 weeks. There's no pre-medications required because there are no infusion reactions. And so it's a new mechanism, and so we'll be able to have even more diverse combinations with the use of this drug. If we look at the DREAM2 phase 2 trial, it enrolled 196 patients with relapsed refractory disease. These patients had to have been refractory to an immunomodulatory agent, a proteasome inhibitor, and either refractory or intolerant to an anti-CD38 monoclonal antibody. The response rates, they compared 2 dose levels, 2.5 milligrams per kilogram versus 3.4 milligrams per kilogram, and they didn't see a difference in overall response rate, similar in both arms. They did see an improvement, though, in the lower dose in keratopathy, which are corneal deposits on the cornea, thrombocytopenia, as well as anemia. And so the indication is at 2.5 milligrams per kilogram. Now, the keratopathy is a new side effect that most patients in myeloma are not used to, so we need to make sure that we're educating patients on the signs and symptoms of keratopathy. So they need to know that if they have trouble with blurry vision, if they're reading a book and they're having trouble with their vision, or if they're having dry eyes, that they report that right away and not wait until their next infusion. Some exciting data was presented at ASCO of the DREAM6, where they combine belatmab mafodotin in combination with bortezomib and dexamethasone in patients who had at least one prior line of therapy. It was found to be safe, and the response rates were about 3/4 of the patients responded to that regimen. We're going to move on to melflufen now. So the mechanism of action is unique. So we know that peptidases are expressed in myeloma. And so the melflufen is taken up by these myeloma cells very quickly. And that when that happens, it immediately cleaves to the peptidases. And then the alkylator becomes entrapped, and it rapidly induces irreversible damage, which causes apoptosis of the myeloma cells. So if we look at the Horizon 2 data, we can see that there were 154 patients with relapsed refractory myeloma. They had to have had progressive disease at study entry, and over half the patients were refractory to an IMiD and a proteasome inhibitor. Half the patients were refractory to an anti-CD38 monoclonal antibody, and almost half the patients were triple-class refractory, meaning they were refractory to an IMiD, a proteasome inhibitor, as well as an anti-CD38 antibody. So it's a heavily pretreated group of patients. And if we look at the response, again, the response was about 30% of patients, which is what we would expect in a single agent trial. And if we think about melflufen as well as belantamab, if we think about the response rates of around 30%, same with selinexor, that's quite impressive given the fact that bortezomib and lenalidomide had similar response rates when they were studied as single agents. The most common adverse events would be what we would expect with an alkylating agent, which would be cytopenias, infection, and febrile neutropenia. So again, these patients need to be monitored for their blood counts and also instructed on infection prophylaxis, as well as monitoring their fevers.
So Tiffany, can you update us on CARL? There are so many choices for patients with multiple myeloma, especially all the options on clinical trials.
Of course, as you mentioned, CARL has there's so many different options, right? And so we discussed with him clinical trials first because we had some trials with belantamab at our center, as well as some CAR T cell. He really wasn't eligible for CAR T because he needed to start treatment right away. And he really didn't want to go on a clinical trial because he really wanted to take an oral regimen. That was really his preference. And so he started on selinexor. We did start him on antiemetics, so he was placed on ondansetron and olanzapine starting at day 1. And we provided him with extensive patient education materials and monitored him twice a week. He did require a dose reduction due to hyponatremia, but after that, he actually did really well and did fine, and is having a response actually and remains on selinexor. We did talk to him about future plans of using venetoclax, particularly since he has that translocation 1114.
Thank you, Tiffany, for sharing Carl's case. His was a great example of how nurses can really support the patients, using a 5-HT3 receptor antagonist like ondansetron and bring him in for fluids and really supporting him through there. I think that's really important to give them a chance to tolerate. In my experience, if they can get through that first month and even the second month, then they can really do a lot better. Tiffany, anything else that you'd like to talk about with the emerging drugs on the horizon? Maybe other drugs that we haven't discussed today?
Yeah, so I think it's exciting that hopefully we'll be having even more drugs in myeloma and more different combinations. Venetoclax in combination with bortezomib, belantamab in combination with other drugs, combining melflufen with other drugs. And I think what's particularly exciting is the CAR T-cell therapies and the anticipation of an approval for CAR T-cell therapy in myeloma. I think also with the anticipation of potentially an off-the-shelf CAR T product so that patients don't have to wait so long for manufacturing of their T cells before receiving their T cell infusion.
Absolutely. And one of the things that we struggle with clinical trials at our institution is sometimes patients wait too long for that next trial, so their counts might be a little bit lower than they need for the trial. So again, really, nurses should encourage patients to learn all they can about the clinical trials available before it is too late. So this has been a wonderful discussion so far. I'd like to do a few more concluding thoughts. New drugs and new classes mean healthcare providers need more and more education when and how to use the drugs, how to manage side effects, and look at the selinexor needs a lot of love, I say, but it's a good medication for many people. So learning opportunities as new drugs are approved are also very important. I'd like to share with you just a brief mention about the International Myeloma Foundation's research initiatives. The Black Swan and the iStop Myeloma, I've been so excited about the last few years. Think of an idea of a black swan. We used to think there are only white swans around, and then all of a sudden somebody saw a black swan. That is similar to the idea of cure in myeloma. In the 1990s, when I started managing patients with myeloma, I couldn't have dreamed that we'd be talking about cure. Now we can detect 1 in a million plasma cells, 10 to the minus 6 MRD negativity. So what the Black Swan Research Program is looking for that functional or absolute cure. There are cure trials available with MRD negative, and then studying the resistant disease in patients who aren't achieving the MRD negative status. iStop Myeloma is one of the Black Swan trials, and this is an initiative where Iceland screens, treats, or prevents multiple myeloma. It's a clinical study in which 80,000 individuals will be screened with MGUS, smoldering myeloma, and multiple myeloma being identified. Decode genetics are available for all these patients, and now researchers are analyzing these data to really understand clues to possible causes of MGUS, smoldering myeloma, and multiple myeloma, and understanding how early does MGUS actually evolve.
Thank you, Beth, for sharing today's discussion. During the discussion, we discussed selinexor, which is a recently FDA-approved treatment for myeloma, clinical trial options for patients at any stage of disease, treatment options currently in development, such as venetoclax, melflufen, belantamab, as well as exciting phase 3 clinical data leading to approval for these agents. We'll continue to watch for data on some exciting myeloma treatments in earlier stage development, such as CAR T-cell therapy and T-cell engagers. And then, of course, the IMF's Black Swan Research Initiative to develop a deeper understanding and a cure for myeloma.
Thank you, Tiffany. With all the ongoing research, there's so much hope for improved treatments and a better way to use the treatments that we have and learning new treatments and perhaps, hopefully, one day a cure for our patients with myeloma. Thank you for joining in this discussion, and please watch the companion videos where Joseph Terriman and I discuss newly diagnosed multiple myeloma, and Amy Pierre and I discuss treatment options for early relapse patients with multiple myeloma. In order to receive your 0.5 CNE credit for watching this video and to download your multiple myeloma resources, please complete the post-activity evaluation. Thank you for joining us.